This video today is about my journey to learn doing Phaco with the left hand, and this is the 6 months period which has elapsed since I started using this technique. Now this is one gentleman who was being operated upon, and because the steep axis was such that I had to make an incision at something like 20 degrees, and this is the right eye of the patient, so it was necessary for me to use this location which was convenient for my left hand to approach using the phaco handpiece. Another option could have been that I could have made an incision in the inferotemporal quadrant, but sitting at the head end is more comfortable rather than using my right hand and sitting at the temporal end. So rather than switching positions, I decided that I'll switch hands and for such cases. And this is how I have learned to do phacoemulsification using my left hand. There are few things which I will particularly point out for those who want to learn doing the phacoemulsification using the non-dominant hand. And first of them is that capsular axis is the most trickiest part to learn using your non-dominant hand, or the hand which has never been used to perform our axis. Because I use a capsular axis forceps, so that has taught me few more issues, that when you are doing a capsular axis using a forceps, the vector forces are not only the one force which is being acting tangentially to shear the capsule and create a tear and opening, but there is one more force which is directed in the vertical plane. Now this force will usually also play a part when you are holding the capsular axis flap and moving the forceps up or down relative to the capsular plane. And if you are pulling it up, it will inadvertently cause the tear to extend to periphery. And this is something which I never realized when I was using my right hand, because it was so very natural that I adapted to it. The rest of the things are not very tricky, but yes, when it comes to nuclear disassembly and the aspiration of the cortex, it becomes a little difficult and one has to adapt a little bit. But overall, the capsular axis part is the most trickiest part to learn when you are switching your hand from your dominant hand to the non-dominant hand. Now, proceeding for phacoemulsification, one has to keep on consciously reminding oneself that it is the left hand which has to go first rather than the right hand which used to go first, and same about exiting out, that the right hand has to exit out first rather than the left hand which is conventional for me. And this will initially cause some occasions when you will have a situation where you have pulled out the phaco handpiece and your chopper or dialer is still inside. So you have to learn that and remember that. The rest of it is like because I am using a horizontal chop technique, so you keep the phaco tip in the center and take the horizontal chopper up to the periphery of the nucleus and then approximate these two instruments, lacerating the nucleus, crushing it, and then making a virtual L so that these pieces are separated out. One has to take some patience and some careful adjustments so as no unwanted accidents occur. Although I have found that disassembly of the nucleus is never a problem if you are just being little conscious about your movements. So once you have disassembled the nucleus, the rest of the technique is that you try to keep yourself in the center and keep manipulating the pieces using the chopper so that the handpiece or the phaco tip doesn't move much, and it is usually much of the job is being done by the dominant hand at the present, which is holding the chopper and manipulating the pieces so that they come in front of the phaco tip. Occasionally one may need to chop a large piece into a smaller fragment so that it can be consumed easily. So here we can see that maneuver, and then rotating the nucleus remaining piece so that it comes in front of the phaco tip, which can be safely and easily emulsified. One has to be careful when removing the epinucleus, because at this moment it is possible that there may be some amount of surge, because there is no protection for the PC at that moment. Now, regarding the process of removal of the cortex, because this is a process where the aspiration port makes it mandatory that the orientation, that is the torsional or the rotational orientation of irrigation aspiration cannula, is in correct orientation. And I have had experiences where just because I was not properly orienting the aspiration port, I created PC tear in few of my cases, to be exact 2 cases. So one has to be again very conscious when you are manipulating your irrigation aspiration handpiece, and you have to take care that your aspiration port is very much visible to you and it is not as intuitive as it happens with your dominant hand. Once the cortex has been removed, one can check if there is any remnant cells or fiber remaining on the posterior capsule. You can polish it at low aspiration and low vacuum setting of the foot switch using the IA handpiece also, or one can simply switch to polisher, which is a blunt ring like instrument which can be used to polish the posterior capsule and also the anterior capsule under methyl cellulose or viscoelastic, whatever you are using. This is one very safe technique to polish the capsule, and I have seen my teachers using this and spending some time to polish the capsule, more importantly the anterior capsular margin or the rhexis border, which is supposed to harbor the potential dividing cells which will keep on adding to the occurrence of posterior capsular opacification, and this technique will take care that there are least of proliferating cells left behind, and so this will affect and reduce the occurrence of posterior capsular opacification. Although nowadays we all depend more on the IOL design and material for retardation of this process, and in any case if it happens, you can always do a YAG laser capsulotomy. This patient also has asteroid hyalosis, as we can see those white opacities in the vitreous cavity. Now proceeding on to implanting a hydrophilic multifocal IOL, and this is a single piece IOL, and the trailing haptic has gone into the bag, and we just need to see using a dialer to confirm this fact. Another fact which I find, that dialing with the right hand is much more easier, and I am more confident when I am dialing with the right hand, because now we have the side port which can be used to dial these IOLs. Now placing an opposite clear corneal incision as planned, because this patient had a corneal astigmatism of 2.75 diopters, and this is a nice tool and opportunity to reduce the corneal astigmatism so that the patient has all the benefits which can be harvested out of implanting a multifocal IOL. Least of corneal astigmatism is going to help in reducing the possibility of patient for using a spectacle correction for his best corrected visual acuity. Going behind the IOL, lifting it up to aspirate any cells or viscoelastic which is trapped behind. One again has to take care that the aspiration port is always visible and towards you, because left hand or the non-dominant hand is not used to using the irrigation aspiration handpiece as fluently as with the right hand. Surgery has been done, the IOL is implanted, it is in the center, and we are now inflating the anterior chamber and also hydrating the wound if it is needed. I always like to flush the anterior chamber a little bit before sealing it, so that any amount of viscoelastic which was left behind and not aspirated during the procedure can still be removed using the flushing technique. This is the patient's photograph of the anterior segment day 1, which shows some amount of keratitis, and this is the photograph at day 30 when the patient was given final refraction and the corneal astigmatism had reduced from 2.75 diopters to 0.75 diopter of cylinder. Thank you.